Thank you very much for having me today. I'm actually more nervous speaking here than I am at the normal meetings I speak at, and I think it's because, my background is I'm an ocular oncologist and a surgeon. I work in Sheffield predominantly, but I spent some years working in Moorfields as part of the service there. And normally, I'm telling people what I want them to know. So it's my stuff that I think other people would benefit from. I'm going to imbue them with some sort of knowledge that I want them to have. But when Jo invited me here today, I was actually really keen that it was relevant to you. And so I asked her what kinds of things she gets asked that hopefully I can try and answer a little bit. And I also went to my clinical nursing specialist in Sheffield and asked them, once they leave the room, I've told the patient their diagnosis and their treatment and answered their questions, but there's a lot of one-way traffic in those consultations, and the honesty comes out in the counselling room afterwards, and they talk to my nurses in a way that they might not talk to myself and my colleagues. So I've tried to compile the questions that seem to be the most popular ones, the ones we hear more often, and I'm going to try my best to answer some of those today. So it's roughly broken up into 4 separate questions, but actually there are multiple questions laden within them. So I'm going to do my best to try and break them down and talk about it. I appreciate it's been a long day for all of you. You'll be glad to know there are no long words in this. And the idea is that this is the kind of stuff I talk to my patients about all the time, and I'm hoping that it might resonate with some of you. Equally, if these are questions that are not relevant to you here, I'm more than happy for you to chip in, actually, because it's been a long day and I'd rather it was relevant and you got something out of it. I don't think this is working anymore. Oh, okay. Forgive me. So I'm going to go really quickly because I think you guys know more about ocular melanoma than many people. But as you all know, most people are affected by uveal melanoma, not conjunctival, just because of the incidence. Can I get a quick show of hands? How many of you are interested in uveal melanoma? So, as expected, most of the hands. Anybody here for conjunctiva? I will answer your questions, but slightly differently. Okay, and that's because, as most of you will already know, there is a difference between the two, but you're all part of the ocular melanoma family. So ocular melanoma, uveal melanoma, is tumours in the eye, okay? And you've seen this image already today. It shows you how there's not actually that much out there and everything gets repeated over and over again. And most of my patients come in with either a very small something sticking through the coloured part of the eye or a completely normal looking eye. And that's the bit that throws many of my patients because they go, I'm so well, I had no idea, it's literally come out of nowhere. And that in many ways makes them less prepared to start that journey, and you may be able to relate to that yourselves. Here is a particular patient of mine that is just like that. So he had something poking through the coloured part of his eye, but then when you shine a light, you can see there's something much bigger. It's normally the tip of the iceberg that you're seeing at the front of the eye there. So conjunctival melanomas are usually quite different. You can normally see the problem. And normally the patients or their opticians have gone, I can see something there. And that's because the translucent skin that's over the eye and lines the eyelids is affected. And here is an example of a patient. They knew they had it before I knew them, if that makes sense. So that's usually quite different to the uveal melanoma patients. So I think this is the big question, okay? And I think most of my patients have asked me this directly, or have asked my nurses this directly, or have at least asked themselves this, okay? And it's actually quite hard. I think it's a multi-layered question. At least for a minority of my patients, what they're really asking me with why me is, have I done this? And that's quite different because that's layering with guilt and concern that somehow they've walked a path that's taken them into ocular melanoma. And these are specific questions I get asked all the time. Actually, a lot are, I'm sorry to say it, husbands asking whether their wives not going to the gym is the reason they've got an ocular melanoma. And so that's quite an interesting dynamic that you probably want to unpick separately. For uveal melanoma, it's almost always no. You have done nothing to deserve this, okay? Almost always. And even if there's that subtle, well, I would still say no, because actually, is guilt going to help? Not really. And the vast majority of the times, they genuinely have done nothing. It's just sheer bad luck. Conjunctival is slightly different because we do know that sun exposure can have an effect. We do know there seems to be a smoking association. However, How many people do we know that love the sun? How many people do we know that smoke? And conjunctival melanoma is so rare. It's not as simple as, I shouldn't have enjoyed those sunbeds. You know, I just think that's too much hitting with the guilt stick, and I don't think it's helpful. And actually, why have you got it and the hundreds of thousands of people that do exactly the same haven't? So I think for now, I think it's more complex than that, and my answer is still no. The other side of the why me question, I think, is, well, has something else done this? Okay, so maybe not me, but has something else caused it? And the picture of the eyeball is to remind me that sometimes there are conditions you have which make you more likely to develop your ocular melanoma. And this particular one is ocular melanocytosis, something you're born with. It's not something that runs in families, and it increases your chance of uveal melanoma quite significantly. And if that's picked up, you're the kind of normal person that needs really close screening in hospital, unlike, say, most people with a benign-looking nevus. But within that, there's really is it in my family? And again, I think that's a multi-stranded question. I think people are really saying, what about my kids? What about my grandkids? Because they usually know whether their loved ones have been exposed to, have experienced ocular melanoma in the past anyway. They're really going, what's next? So I'm going to spend a little bit of time just thinking about that. Now, again, this is my end of the day version of genetics, okay? We've had some very clever highbrow stuff. I'm a dumb surgeon. I'm pretty good at what I do, but that's all I do well, okay? And I think for uveal, the short answer is really rarely, okay? The vast majority of ocular uveal melanoma patients have no family history and are not going to pass that tumor characteristic onto their offspring. So it's almost always no, all right? A small minority might know someone. It may not be a first-degree relative. It may be a cousin or something like that. But we don't fully understand the genetics of these family trees yet. There's only really 1 or 2 cancer predisposition syndromes, the BAP one being the big one that we know about and can test for. So this is still a work in progress. Some estimates say in the US, you know, big country, lots of Caucasians that get uveal melanoma, 1 in 50 million, something like that, have familial. It's like crazy. No, sorry, I'm misquoting myself. So 1 in 50 million get bilateral, which is thought to be familial that they don't know about. Does that make sense? So let me just unpick that again. When people are asking me, is it familial? They're either thinking about their kids or they're thinking about, am I going to get another one? And that's 1 in 50 million, according to this study in the US. So it shows you how rare it is. So again, my answer to my patients is no, probably not. All right? And usually in the beginning phases, that's enough. Certainly when you're going through the beginnings of your journeys, which I appreciate is not the majority of you here. Conjunctival's a bit different, okay? And that's because there are certain conditions which you usually know about that often run in families that make you at higher risk of cutaneous cancers. And the conjunctiva is very similar to the skin stuff, so they cross over. So you normally know if you have that condition and you normally get screened for it. Other than that, we don't know. It's too rare. It's so rare we don't have good data to be able to look for enough trends to know. So that's the why me bit. Is everyone happy to move on? Is there any part of why me that I have not addressed? I think everyone's asleep. I might just go with that. So this is the next commonest question that maybe happens later down the line, and this might be more relevant to those of you here, is you've been through the journey, you've gone through the beginning bits, you've had your treatment, and then you get to know other people, okay? Maybe they live elsewhere in the country, or, you know, you find out, funnily enough, that you already know someone in your street that's had uveal melanoma. That happens so often, it's bizarre. That they go, well, hang on, well, why did you, and why didn't I, and is that better? And it brings up a lot of questions. So I'm gonna try and, again, unpick that a little bit. So again, right back to basics, okay? There are multiple treatments. Again, uveal melanoma, but I'll tell you where the conjunctiva crosses over. Most uveal melanomas in this country are treated with ruthenium plaque brachytherapy. So that's the silver disc that gets sewn over the outside of the eye, over where your tumor is. So if it's something I've got to sew over a tumor, and they only come in set sizes, your tumor has to be small enough to fit in that set size. That's you know, as simple as it is. It can't be bigger than the size of the plaques that are available. And if there's something sticking out the eye, for example, the nerve that we all have that connects the eye to the brain, and your tumor is sat right there, your plaque won't fit over it, because I can't chop the nerve off and still have an eye that's working for you. So there are some real physical restrictions as to which tumours and which patients can be treated this way, although the majority are treated with this treatment. You need 2 operations for this, those of you that have had it or know someone that have had it, and that again can be a rate-limiting step for certain patients. The next most common one is probably the proton beam. I quite like these pictures for you to appreciate the size of the clips that get sewn on. Sometimes you don't get to see these before they're put on your eyeballs. They're tiny. Does anybody know anyone that's ever had Sylvanian families? You know, the little toys? They're about the size of the buttons on the, they're tiny, tiny, and we lose them all the time. It's an absolute nightmare. So you have to have an operation to have those stitched onto the white coat of the eye around your tumour. And then you spend a week on Her Majesty's pleasure outside Clatterbridge having the treatment there near Liverpool. And again, you have to be well enough to have that one operation. So the first treatment's 2 operations, this is 1 operation. But then you get your radiation coming from outside in as opposed to coming from that radioactive plaque. Third one I don't think I heard mentioned before, and that's because it's not used everywhere. This is stereotactic radiosurgery. It's the only place you can have it in the UK is in Sheffield, although you can be referred in for it. The big perk with this is although the frame you have to wear looks dramatic, this is all done under local anaesthetic, no operations, and it's a one-hitter. You turn up the night before, you have all of your treatment in the morning, and you're home by dinner. And so this suits certain types of patients that are prepared to travel to Sheffield and have a tumour that's in the appropriate place that we can treat it. And I know this sounds really silly, but has the right shaped neck to fit in the machine. So if you're a no-necked individual, this can be a real problem. And that's because this was designed for brain tumours. Okay, so it's all of the centering of all those beams of radiation are better off in the bonds as opposed to further forward. So you need to be able to get far enough back to get the melanoma in the right place. So again, there are some physical restrictions as to what can and cannot be done for you. Surgery is the big one. So conjunctival tumours tend to be treated with all of those radiation modalities with the exception of stereotactic, or get a lot of surgery, okay? And so that's where I come in. And of course, if your tumour's too big for any of those radiotherapy options, or for whatever reason it doesn't suit, enucleation is probably the path you will go down. And then the small print, okay, some people get laser. That's not available everywhere. It doesn't tend to be as effective as the radiation or surgery-based treatments, but it's an option for certain patients. And then you've got the research end of things, which I'm not going to go into today because I think we're a little researched out after 5 o'clock. But equally, it's not available everywhere, so I think it's less relevant to many of you here. So they're the different treatments. So why different treatments to other people? And I think there's lots that go into this. These are the kinds of things that will go through my mind in clinic when I meet a patient. I'm thinking about the tumour. Is it physically small enough to fit in a plaque? Is it too near to the optic nerve for me to put a plaque on it? Is it in the right part of the head to be treated with stereotactic or proton beam? All these things I've got to think about. Is it too big for all of that? Is the dose of radiation so big you're going to end up getting a painful blind eye sooner rather than later, and then actually would have rather have had the eye out in the first place? So I'm juggling all those things, just looking at the tumour before I even bring the patient in, using the scans. And then I've got the patient, okay? The good Lord saw fit to give most of us 2 seeing eyes, but that's not true for everybody. And if their other eye is not going to be good enough for them to live their life the way they want to, I need to think really carefully about the treatment I offer, because there may be something more effective at killing the melanoma, but that will actually destroy their vision more. And that patient may not want the most effective treatment because the price is too high for them. Then there's things like their physical health. Can they have 2 operations? Can they have 1 operation? Can they travel? And ultimately their preferences. I'm the kind of surgeon that really likes the patient to make the decision for themselves. I can make recommendations and signpost, but I really want them to understand and choose, because ultimately I go home and they live with that decision. So I think it's important that's a decision they can live with. And I'd love to say that was it, right? That they are the only factors that ever come into play as to why different patients are recommended different treatments. But the fact is there's more to it than that. You've got the doctor, the individual doctor that sat in front of you, and I'm going to come back to that because I think that's something that maybe I can give insights to that you might not necessarily get a chance to hear another way, so I'll come back to that. And then there's something about service. So if you happen to work in Liverpool and Clatterbridge, the proton centre, is across the way, your patients are usually more prepared to travel there because it's familiar than you would if you're from Penzance. And there are things like that that really do affect a patient's choice and what they would like to have in the long run. There's also a difference in expertise that's available in different centres. It's not a one-size-fits-everybody. For example, Liverpool, both surgeons are trained in a very specific subspecialty, so they tend to approach things in that way because that's where their skill set comes from. And that same skill set isn't necessarily available in the other centres. And so it will affect the flavour of the recommendation they make because of what expertise they have in-house. So of all those 4 things, and there's probably other things in there as well, like the weather and goodness knows what else, but really, I want to reassure you that the first 2 are the most important. Tumour is the biggest constraining factor, because if it's not the right shape, size, place for me to do something, there's no point in me offering it to you. And then it's what the patient wants. So I want to come back to the doctor stuff, okay? So there are 11, 12 ocular oncologists serving the United Kingdom? Not many. I know them all because it's a small community, and each and every one absolutely wants to get it right for every patient, because we like to sleep at night and you don't come into this job for any other reason than to feel like you're doing good. But we all disagree passionately about what that looks like, okay? And that's because it's a rare cancer. The evidence is growing, but it is not perfect. And the evidence isn't strong enough to tell us that this treatment here is definitely better than all these other treatments. It just doesn't work like that. The evidence isn't strong enough. Even the debate between do we watch small things or treat small things, you put a room full of ocular oncologists and you will get people on every side of that argument. It's just that difficult to find one crystallizing, unifying opinion. And so if you end up in front of somebody that strongly believes in, say, actually, I think if you're going to get metastases, it's probably already started, so blinding you is not going to save your life, they're more likely to say, why don't we wait a bit longer? But if you're sat in front of a surgeon that goes, I believe that treating this as early as possible is the best thing for you, then you're more likely to get offered treatment earlier in your pathway. And so I didn't know if that was something new, something you were aware of, but that's certainly my living, breathing experience of being an ocular oncologist. And the room you're in will change the flavour of the opinion because of what people really passionately believe, but there's evidence on both sides, and that's what makes it so hard. Is there anything more you think I can add about the doctor side of things before I move on? Really are all asleep now. So then we've talked about why different treatments for different people. We've talked about the why me. So now it's, well, why is my follow-up different? And I think follow-up can be broken down into multiple questions as well. The big debate is surveillance. There's stuff looking for spread. Liver for uveal patients, neck lymph nodes for conjunctival patients. And then we could talk a little bit about other treatments and the where and the how often and that sort of thing. But I think the surveillance thing is the biggie, really. That's the one that people care the most about, and it's the question I get asked the most often. So the great surveillance debate, okay? There are at least 2 camps, all right? But I'm going to take a step out of my comfort zone. I do ocular cancers only. I know in the room we've got some esteemed medical oncologists that deal with other cancers. And let's imagine we were talking about a different type of cancer that's much more frequent. So NICE and all these big organizations have taken a very close look because it costs them a lot of money to treat all of these hundreds of thousands of patients that have all of these same tumors. They come up with rules, right? So if your risk of spread is below a certain level, you can't have screening because it's not worth it. There's no, you'd have to screen too many people and all of those scans be normal because you're so low risk. So then the guidelines say you can't screen them. You should screen the high risk ones. So we don't have that level of sophistication with uveal melanoma. It's getting there. But at the minute, we're so small that no one's looking at us. So there is a certain amount that your ocular oncologist is a little bit allowed to do what they want to do because no one's scrutinizing too hard, which then gets back to the doctor characteristics I was talking about. It then becomes what's their opinion. based on the science, but the science, you can use it both ways because the evidence is still being built up. And so the two big camps really in uveal melanoma screening at the moment is scan everybody regardless because no one's looking, and hey, why not? And then you have the other camp that's going, no, we need to be individualized here. Let's focus our resources, our energy on the highest risk patients and maybe do MRI for the highest risk patients, ultrasound for maybe the medium risk, and the low risk don't need any screening. Now you can imagine how popular that is. The ones with the high-risk tumours love the idea of being guaranteed MRIs, okay, because they feel like they're getting something in addition. But the ones that get told that you're too low risk hate it. They hate it, okay? And the truth is we don't always get it right. There are patients that are high risk that never develop mets, seem to live for years and years, and that's wonderful. And we have patients that are low risk and are really unlucky, and it floors us every time. We know it happens, but we hate to see it happen, because you're just not expecting it and you're not prepared for it as a clinician, never mind the poor patient and their relatives. So if I'm honest, you can probably guess which camp I sort of sit in. I'm more in the camp of scans for all, but to do that, I've got to be sensible about which scan I choose. I cannot give MRI scans to everybody. And if I tried, I would very quickly get scrutinized and get told I can't give them to anybody. And so there is this tightrope that you've got to kind of walk. Sheffield's a bit different to Liverpool and London, the other English centres, because we don't have a great connection with individual medical oncologists to take over the scanning. So we do it in-house. So we are having to make quite difficult decisions, and we are not trained like a medical oncologist to be able to have that conversation and go, I'm sorry, you're 97. Even if we find mets, you're probably not well enough because of all of these reasons to have any of the treatment, so you shouldn't be scanned. At the moment, everybody gets scans in Sheffield, and you can argue the merits of that. But for now, it's better that we don't miss any mets, is the way we're falling on that, whilst we don't have a system in place. It's quite challenging, actually. There's a lot to it. But none of it is that we don't care, and none of it is that we care about the money, because we don't pay for it. It's more a case of having to balance something we can sustain and offer fairly without really putting anyone in danger. I'm sure you've all heard the debate, MRI versus ultrasound, a million times. Is anybody interested in rehashing that today? No, I think you've all heard it a million times over anyway. So these are the other things that feed into follow-up. So each individual tumour, depending on how well the treatment goes or which treatment was selected, has a varying degree of risk of recurrence. And so if I think you're higher risk of recurrence for whatever reason, I might watch you more closely. Different eyeballs have a different risk of getting complications of treatment. So for example, if you're a diabetic patient that already has some retinal detachment, you're much more likely to have big problems later, so I'm going to watch you a bit more closely. So you will find that clinicians do try to tailor how often they see you and whether they keep you in-house for follow-up or whether they, what we call repatriate, send you back home for an eye doctor to watch your tumour, and it depends on all those things. But again, that varies by geography. You know, Liverpool are very quick to send you back home. That's the way they've always run their service. Works well. Sheffield have traditionally kept everybody, and I'm not exaggerating when I say I'm having to discharge my predecessors' patients from 25 years ago. So that's clearly not a sustainable system because you can't get new patients in whilst you've still got patients that have been normal for 25 years. So there is a balance to be struck, but you'll find that lots of little things like that will feed into why your follow-up might be a bit different to someone else's. So this is my last question this afternoon, and I think this was put to me by both yourself, Joe, and by my clinical nurse specialists. And I'm going to start by going, I am not the right person to talk. I think that the wealth of information in this room is infinitely more than mine on how you can help yourself from the holistic side of things, the support and that sort of thing. And I would say reaching out to each other and to the wonderful psychotherapy. We send a lot of our patients to the counselling services run by Ocumel. So I think help, certainly that's how I'd read that question the first time round, is how best to approach it, and I'm not the right person to tell you that. So, but what I thought I could add is maybe the more medical-y side of things, okay? So, So these are the kind of medically questions I get asked. So this is down the line. Usually I've known the patient for a while and they've gotten over the shock and they're recovering and they've gotten used to their vision loss or their double vision or whatever it is. And they're now going, okay, now I'm ready to live forever, so what can I do? And a bit like my very first question of what did you do to cause it, actually there's not a lot of evidence about all of this stuff. Anything that makes you healthier can't be a bad thing. But it doesn't seem to affect whether you're going to get spread or not and how long you live with those metastases or not. My favorite question, though, is about drink. So there's a lot of people that think because it's the liver that the metastases tend to go to, particularly for uveal, they go, well, do I drink more to pickle the cancer? Or do I drink less because I've got to give my liver cells a chance? And I love these kinds of questions because it gives you a real insight into the kind of questions people must be discussing at home around the dinner table. You can see I'm a Muslim lady. I couldn't possibly condone extra drinking. But I also wouldn't deter you. There's no evidence. So you do whatever it is that makes you happiest. And if what you want to do is go probiotic and only eat a paleo diet and never drink another thing the rest of your life, if you're happy that way, go for it. If you want to get sloshed because it's a bit hard, go for it. You know what I mean? There's no good evidence either way. The one I would say is people ask me a lot about eye protection. And actually, I almost never care about the eye that's been treated. I know that sounds really silly, but that's no longer your primary concern. If you're a survivor with ocular melanoma, keep your good eye healthy. That's where you put your energy. And I think if you are prepared to wear eye protection, if you're a gardener, gardening's a biggie. I don't know how many people get sticks in their eyes. Squash is another big one because that ball is just small enough to rupture your eye if you get it hit straight in. Protect your good eye as much as you can. My husband's not allowed to play squash without his really geeky goggles on. He hates me for it. So yeah, there's a few kind of do's, and these are very medical do's. These are not the kind of the holistic things, but get regular optician checks. Just because you've been unlucky enough to have ocular melanoma doesn't exempt you from all the other things that can go wrong with your eyes. Make sure you're wearing your eye protection, and then be your own advocate. I don't think the NHS is what it used to be. I'm not the oldest consultant on the block by some margin, but even in my career, it's not as robust as it once was. And I think patients have to really be their own advocates, keep a track of your scan dates, make sure that they're happening on time and chase them. If you're not sure and you want to delve into something, I've obviously done a very general, sweeping answer to these questions, but it will vary on the individual. And I've never once turned a patient away that wants to know something, but I've appreciated a heads up that they might want an in-depth conversation that I can't do in 10 minutes. So what I find is the patients that maybe contact my nursing team and go, I really want to talk about X, Y, and Z. I've got a little bit of leeway. Okay, give them 2 slots, or maybe look ahead of time. What trials are available to me? For example, I do appreciate a heads up because I'm not necessarily at the cutting edge of metastatic uveal melanoma in quite the same way as I am with the primary, because that's really the focus of my work. But it's always a conversation I'm happy to have, and I think all my colleagues would be in the same place. But a heads up is usually quite helpful. And talk to us. Genuinely, most of us are lovely, especially sober. And I think that's my last slide.